Hello friends. So in continuation to yesterday's lecture regarding diabetes in the last minute division point, today we'll talk about chronic complication of diabetes. First of all is cardiovascular complication. These are 3 to 5 times more common in diabetes as compared to non-diabetic patients. Okay, and in fact the most common cause of death is coronary artery disease in diabetes. So this is most common cause. Not only CAD occurs, even the peripheral vascular disease is very common in these patients, and that lead to gangrene. What type of gangrene it is? Wet gangrene. Wet gangrene. Again, a very commonly asked question. It spreads very fast. This is in contrast to Berger disease where we have dry gangrene. So this spread very fast. That's why diabetes is the most common cause of amputation in the world, next to trauma. Of course, trauma is the most common cause, but if trauma is not the option, then diabetes is the second most common cause of amputation in the world. Well, now we have a new thing, legacy effect. Legacy effect, also known as metabolic memory. Metabolic memory. So what is this? This is related to cardiovascular mortality. Mortality. This is the prospective new question. PNQ stands for new question. So now let's learn the basic concept. What do you mean by legacy effect or so-called metabolic memory? Suppose a patient, diabetic patient, come to us. The patient is diabetic for last 15 years, and for 15 years he's diabetic. He come to me right now, and I say you have to control your diabetes, you have to control your sugar, otherwise you are 3 to 5 times more likely to have heart attack. He says, okay, fine, from tomorrow onward I'll control my sugar. So will his cardiovascular risk will fall immediately? No. The cardiovascular risk will not fall immediately. The cardiovascular risk will fall again after 5 to 10 years. Then only his risk of CAD will go down. It will not go down immediately. What I mean to say, body remembers what we have done to the body, and this is known as legacy effect or metabolic memory related to cardiovascular mortality. Now, what is the role of BP control? Role of BP control in diabetes. This is very important to understand. Let's learn the basic concept. I have one patient whose BP is very high, whose sugar is also very high, and this gentleman goes to a diabetes specialist. He reduces his sugar but does not control the BP. His macrovascular complication like diabetes will go down this much only. I have another patient whose BP is high, whose sugar is also high, and he goes to a cardiologist. And cardiologist control the BP but does not control sugar. His macrovascular complication like CAD will go down drastically. What we notice that in a diabetic patient you control sugar only, you don't control BP. Macrovascular complications are reduced only minimally. But if you control BP, macrovascular complications go down drastically. So now the new concept is that if you control only sugar, his microvascular complication go down. But if you control BP, his macrovascular complication go down drastically. This is the prospective new question. So it means in a patient of diabetes, not only sugar to be controlled, BP should also be controlled. Now what is the target? Target is to control below 140 and below 90 in type 2 diabetes. But in type 1 diabetes, it should be below 130 and below 80 in type 1 diabetes. What is the drug of choice in these patients? ACEI is the drug of choice. Why? Because this is a question for you. ACEI. Why? Because ACEI will not only control the BP, but it will also reduce the progression of nephropathy. Now we have one drug, telmisartan. It's a ARB. But it also act on the PPAR gamma receptor. This point is not given in latest Harrison also. But this question has come in May 2016. So now is the latest question. But remember, it is not given in Harrison 19 edition. And this question was taken from my book of medicine essence. It was there in last year also. It is there this year also. So telmisartan, and remember, in PPAR gamma receptor, it was the glitazone, which are anti-diabetic drug which act, but telmisartan also act on these receptors. Now we got new drug, siroglitazar. It act on the PPAR, alpha and gamma receptor. Thereby, it reduces sugar as well as it reduces lipid also. This is a prospective new question. It is not there in Harrison also. It's beyond Harrison. But this drug has been launched in India. You are most likely you will get this question in any of the exam, maybe AIMS or maybe NEET exam. So prospective new question is there. Okay. Now we talk about something about diabetic nephropathy. One question which came last year NEET exam. Which of the following is the earliest question? The earliest feature of diabetic nephropathy. A. Increase potassium. B. Increase kidney size. C. Increase GFR. Increase GFR. And D is microalbuminuria. Okay, which is the earliest feature? Well, let's talk about the diabetic involvement of kidney. What happened in diabetes? First of all, diabetes and kidney. Earliest feature is raised GFR. The answer is raised GFR. The normal GFR is 126. The GFR may go up to 140, 150. In other words, we can say earliest feature is hyperfiltration. Is the earliest. Second one is this is the latest question, microalbuminuria, where the albumin is between 30 to 300 milligram per day. But it is the most reliable marker. It is the most reliable marker for diabetic nephropathy. Up to this stage, if you control diabetic problem, it can be reversed. And which drug can reverse this problem? ACEI. So even if BP is normal, if you give ACI, it is going to reduce the progression of nephropathy. Then comes the stage of macroalbuminuria. And finally, it causes chronic renal failure. Diabetes is the most common cause of CRF in the world. This for the latest question. And one more question which came last year again in NEET exam, that in a diabetic patient, we can have hyperkalemia. Even although urea creatine is normal, that means kidney function is normal, still patient can have hyperkalemia. It's a beautiful question, and this is due to renal tubular acidosis type 4. This is the latest question. RTA type 4 is the cause of hyperkalemia in a diabetic patient. Okay. Now we talk about diabetic and eye involvement in diabetes, especially diabetic retinopathy is a big problem. And all of us know that in diabetic, first of all, there can be snowflake cataract, there can be diabetic retinopathy, which can lead to blindness. In fact, the commonest cause of blindness in the Western country is diabetic retinopathy. In our country also it's a common, but it is not the most common. Well, it can lead to maculopathy. And if macula involved, the vision goes down drastically, very rapidly. Patient loses vision. And of course, then patient can develop glaucoma. Okay. This is due to new vessel formation. So they are the problem what we can have. But what the new question, prospective new question. So we have drugs which can reduce diabetic retinopathy, or which can slow down the progression of diabetic retinopathy. The drug what I'm going to mention right now, they are not given in diabetic chapter of latest Harrison also, but you are bound to get this question in any other exam. The drugs which are meant for diabetic retinopathy is ranibizumab, and bevacizumab. They are the 100% most likely you will get this question, because they are widely discussed in all the conferences. The drugs which can prevent or which can reduce the progression of diabetic retinopathy is these two drugs. Now we talk about diabetic neuropathy. Neuropathy. Most common is sensory neuropathy. This is distal, where patient complain of numbness, paresthesia, and this is the most common neuropathy. As far as motor neuropathy is concerned, it is proximal. It's proximal. It was distal in the distribution of gloves and socks, was sensory, but it's motor, so it can lead to paraplegia. Especially legs are more commonly involved. Paraplegia. Then in the cranial nerve, most common nerve in all is third nerve. And what is special thing about third nerve involvement? Here, despite third nerve involvement, pupillary reaction remains normal. Pupillary reaction remains normal. Again, a last year question is there. Then these patients may complain of painful neuropathy. Painful neuropathy, where these patients, they complain severe pain at night. Okay, it's more common at night time. An unbearable pain may occur, And how we treat this patient? You can treat this patient by carbamazepine, you can use pregabalin, gabapentin, okay, we can even use phenytoin also. And the new drug is duloxetine. This is the latest drug which has been introduced. Now, point to be noted, almost all these drugs, what I am talking to you, they are also anti-epileptic drugs, but they are effective in this type of, why? Because this is not a somatic pain, it is a neuralgic pains. So you can write down the example of neuralgic pains. That's why these drugs are effective in diabetic painful neuropathy. Then we talk about autonomic neuropathy, which itself is a very, very important question. So, autonomic neuropathy. Now, how patient manifests? Postural hypotension. Okay, this is one manifestation. Number two, unexplained tachycardia. Heart rate is very high, unexplained. We don't know why patient has tachycardia, you think about. Diarrhea in 95% cases. Constipation in around 5% cases. Point to be noted, in these patients both can happen, but diarrhea is much more common as compared to constipation. Fourth, erectile dysfunction occurs. For this, of course, we give sildenafil, everybody knows, which is nothing but Viagra. But what else we can give? We can also give apomorphine, PGE, prostaglandin E we can give, okay, and yohimbine. These are drugs that we can give for erectile dysfunction. Then we have gastroparesis. There is reduced GI motility, there is distension of abdomen occurs because of stomach distension. For this, we give erythromycin. This is a very frequently asked question, which they act on the mortillin receptor. Okay. Again, both are the latest question which came last year NEET exam. Then we have certain special problem what we can, a diabetic patient can have. One is malignant otitis externa. It is called by Pseudomonas infection. It is a very rapidly fatal condition. The patient may have got swelling in the external ear, pus discharge in the external ear, even seventh nerve can also be involved in this patient. Okay, so you have to give anti-Pseudomonas treatment in this condition. Second is rhinocerebral mucormycosis. This is caused by fungus, and it is again hair, nose and eyeball are involved. Both these conditions are rapidly fatal if not controlled, and this we treat by amphotericin. Now, one question which come almost every year, a question is I'm asking to you also. You can reply by messenger or you can reply to me at my WhatsApp. This question come almost every year. The question is, which electrolyte imbalance occurs when after we use amphotericin? Option A, hypokalemia. Option B, hyperkalemia. Option C, hypocalcemia. Option D, hypercalcemia. Beautiful question. Okay, all of you can reply by messenger right now, or better you reply me by WhatsApp number, which I'll be giving to you soon. Many of you are already joined, but those who have not joined, you will get a number. But this question comes every year. Don't worry, I'll tell you the answer. Right, sir? Third is emphysematous. Emphysematous pyelonephritis. You see gas in the renal area caused by E. coli. It is again a very rapidly fatal condition if not treated, and most of the time they are not responsive to treatment. Even you may have to go for nephrectomy also. It's so dangerous condition. Mortality is as high as 80%. But main thing is this, the question for you. Well, this is again the question for you. This is question. Now we have an emphysematous cholecystitis. Gas in the gallbladder area. Okay, which both these conditions you can see by X-ray abdomen. But what is unique question about this condition? It is more common in males. Question. Remember, normally gallbladder disease are more common in female, but it's an exception. In fact, this entity is seen almost exclusively in diabetic males, not in females. This is the latest question what came last year. Okay. Then we can also have emphysematous appendicitis. You can write down, the patient can also develop gas in the appendix, so-called emphysematous appendicitis. Now, what can happen in the skin? In the skin, Dupuytren contracture. Contracture are common in these patients. Rather, there can be all the flexor tendon, they may go into contracture. So they go, so you may get like this. So what you get is prayer sign. Prayer sign is like this. The flexor tendon they have gone into contracture. So hand become like this. So-called prayer sign is seen in diabetes. There also occur thickening of the skin over the hand. This is known as sclerodema. It is not sclero, it is sclerodema, seen in diabetic patient. And one more question, necrobiasis lipoidica. This is most common in the shin area. This was the latest question. Last year question was, what the most common site of necrobiasis lipoidica? Answer is shin area. Okay. Now, let's talk something extra. In diabetic patients, why and how the complication occur, there are many theories. One of the famous theory of this is sorbitol theory. So let's discuss the basic biochemistry of sorbitol theory. Sorbitol theory. Normally in diabetic, glucose is converted into sorbitol. And this is done by the enzyme aldose reductase. And in diabetes, more glucose, more is sorbitol. And this sorbitol act like a tissue toxin. Many of the complications of diabetes like retinopathy and other things, they occur due to increased sorbitol. So they knew this reaction for last 50 years. And for last 50 years, they are trying to get a drug which should be a aldose reductase inhibitor. Only 2 years back, they got a drug, apalristat. Remember, it is not an anti-diabetic drug, but it is a aldose reductase inhibitor. Aldose reductase inhibitor. So it reduces the sorbitol level, thereby it reduces the complication. So it reduces the complication. And this is the new drug, prospective new question. This is not given in Harrison also, but this question will surely come because in all the conferences they are talking about this particular entity also. Okay, friends, so this was about the chronic complication of diabetes, and on Monday I will be talking more about the endocrine diabetes. I'll continue, then I'll be talking to you about whole endocrine in the next week. And my target is to finish the whole medicine with you. Of course, bit by bit. My target is to finish the whole medicine in by just maybe second week of December. So you have enough time to revise. So now let's have a quick last minute revision points. Last minute revision point, what you have to carry home, message for you. First point, diabetes is the most common cause of death. Silent MI occurs in diabetes. Earliest dyslipidemia to occur in diabetes is raised triglyceride. In diabetes, wet gangrene occurs. Diabetes is the most common cause of amputation in the world, second to trauma. Then legacy effect is related to cardiovascular mortality in diabetes. Target BP is below 140 and 90. ACEI is a drug of choice. Telmisartan is the only ARB which acts on the PPAR gamma receptor. Sinoglitazar is a drug which can reduce both lipid and sugar because it acts on the PPAR alpha and gamma receptors. Earliest feature of diabetic nephropathy is raised GFR. Microalbuminuria is the most reliable marker of diabetic nephropathy. Diabetes is the most common cause of CRF in the world. In a diabetic patient, hyperkalemia can occur due to RTA type 4. Then we use bevacizumab, ranibizumab for the control of and progression of which control the progression of diabetic retinopathy. Most common neuropathy is sensory neuropathy, which is distal neuropathy. There is proximal motor neuropathy, which lead to paraplegia. Commonest cranial nerve involved is third nerve. And duloxetine is used for painful neuropathy. Postal hypotension occurs in A and P. Gastroparesis occur, which we treat by giving erythromycin, which act on the mortalin receptor. One more problem which occurs is erectile dysfunction. Bladder distension again occur due to diabetic autonomic neuropathy. In addition, we learned about malignant otitis externa by Pseudomonas, rhinocerebral mucormycosis, which we treated by amphotericin. Then we got emphysematous pyelonephritis and cholecystitis. Then we talked about apalristat, which is a aldose reductase inhibitor. So friends, let us see how much time we need to revise the last minute revision point. The time starts now. So diabetes is the most common cause of death. Silent MI occurs. Raised triglyceride is the earliest manifestation. Wet gangrene occurs in diabetes. And diabetes is the second most common cause of amputation in the world. Legacy effect is related to cardiovascular mortality in diabetes. Target BP is below 140 and 90. In type 2 diabetes, of course, in type 1 it's a 130/80. ACI is a drug of choice. Telmisartan act on the PPAR gamma receptor also. Siroglitazar act on the PPAR alpha and gamma receptors. Increased GFR is the earliest manifestation. Microalbuminuria is the most reliable marker. Diabetes is the commonest cause of CRF in the world. And in RTA type 4 hyperkalemia occurs. Bevacizumab and ranibizumab are used to control diabetic retinopathy. Sensory neuropathy is the most common. Proximal motor neuropathy occurs. Commonest cranial nerve is third nerve. Duloxetine is for painful neuropathy. In ANP, postural hypertension, gastroparesis, for which we give erythromycin. Erectile dysfunction, bladder distended bladder occur again due to ANP. Malignant otitis externa because of Pseudomonas. Rhinocerebral mucormycosis we treat by amphotericin. Emphysematous pyelonephritis and cholecystitis, they occur in diabetes. And of course, we use apalristat also. So we have consumed 1 minute and 45 seconds only. Okay, and lot of questions will come from this. Yesterday I got lots of people who joined me on my WhatsApp, and people are constantly requesting me. Those of you who are watching this video for the first time, you can also join me. You can send me your name, your college, which city you are, which year you are, third year, fourth year, final intern, post intern, your email ID, and you can send your information to me in 99682888832. Okay, so I'll be sending you a lot of motivational quotes, and of course I'll be sending you a lot of last minute revision point of other subject also. And as I told you yesterday also, I'll be doing complete medicine with you, and how you should study. Whatever last minute revision point I'm giving to you, you make a separate copy, write down all these things. A day before exam, you go through all these points, and somewhere around 30 to 40 questions will be based on what I am teaching you. 30 to 40 questions are a good number of questions. They may be the turning point for you. They may turn around the table for you. So stay tuned. The class will be almost daily, and I'll be taking some regular tests also in due course of time. But as of now, you can send me all the details, and if you have any suggestion, comments, don't hesitate to talk to me on WhatsApp, or you can even send via Messenger also. I hope you like the class. If you like the class, do inform me. I'll be very thankful. Do inform your other friends also, so that they also get the benefit of these lectures. Thanks again for watching this video. See you on Monday at 4:15. I'll continue with diabetes, and after that I'll be covering thyroid and all the disease of endocrine. After that I'll cover cardiology also, neurology, every topic I'll be covering. Thank you very much. In the next 2 months, complete medicine from Dr. Bhatia. And whole medicine I'll make you revise in just 3 hours. Thank you very much.